Okay, be warned that this is going to be a bit of a geeky discussion regarding coding, billing, evaluation, and management, and modifier 25. As I was getting ready to prepare for the evaluation and management, coding, billing, urologist coding workshop that is coming up this Saturday, at the end of the run of show preparation today, somebody mentioned, oh, by the way, I heard one of the presenters at a recent American Urologic Association coding course and practice management course state that you can't bill anything, you should never bill anything higher than a 99213 with a modifier 25. So obviously that piqued my interest. And I know this person who's a very smart, very passionate physician advocate, really, really smart and well-read, very well-spoken person. And I had to reach out to him because I know him. So I reached out to him and I asked, just want to confirm with you, did you really say that urologists should never bill anything higher than a 99213 with a modifier 25 at the most recent AUA coding seminar? And within a minute, he responded, nope. I said, a level 2 is not significant. Level 3 may or may not be, depends on documentation. And typically, a level 4 is significant due to moderate medical decision-making and medical necessity/risk of moderate complexity. So I'm going to repeat this portion because this is important. It shows his mindset in stating that level 2 is not significant. Level 3 may or may not be, depends on documentation. Typically, a level 4 is significant due to moderate medical decision-making and medical necessity/risk of moderate complexity. So take that in. Take that in for now, okay? Level 2 is not significant in this subject matter expert's opinion relative to whether or not you can bill a modifier 25 evaluation and management. So this is going to be interesting, all right? As usual, if you have any questions or comments, ask now, leave them in the comments below, and I would love to engage with you and answer them during this live stream, or I'll try to answer them after the live stream if you're watching this on replay on YouTube or Facebook. Okay, my response. Significance is not directly related to medical decision-making overall. I would not peg overall medical decision-making level to whether modifier 25 is used or the level which it can be used. And here's an example I gave. I can have a patient who just had a cystoscopy for BPH. So a patient was seen prior, scheduled to undergo cystoscopy, and he comes in for BPH. So BPH is a chronic problem, not a treatment goal. That's why the patient's here for evaluation for the cystoscopy. So that's a level 4 problem. So after discussion of options, the patient and urologist decide to observe his condition. So the patient came in for cystoscopy for BPH, chronic problem, not a treatment goal. And then after the cystoscopy, the patient, you go over the treatment options, and the patient and the urologist decide to observe the condition. Not medical therapy, not surgical intervention, but simply to observe his BPH, which is a chronic problem, not a treatment goal. So it's a level 4 problem. And I state, the global package of the cysto includes the pre, intra, and post-service work, which means making sure the patient's okay to undergo the procedure, the performance of the procedure, and all the supplies that you need for the procedure, and making sure the patient recovers okay, and you telling the patient what you found during the procedure. It does not include the discussion of implications and treatment options, and also the decision to undergo whichever treatment option relative to the findings. Those are significant and separately identifiable items, which, when documented appropriately, and this is the key, as with anything with coding and billing, when documented appropriately, that is a modifier 24 billable E&M. Same diagnosis or problem, BPH, you don't need a separate problem when you use modifier 25. That is nothing surprising there. No new diagnosis is needed for a modifier 25 event. So, same diagnosis and problem, that is a level 4 problem because it is chronic and not a treatment goal or worsening. However, the risk when it comes to medical decision making, the risk in this situation is only a level 2 because you and the patient decided to have him undergo observation, not medical therapy, not management of medication, which would be a level 4 risk. We're just talking about observation, maybe behavioral modification, maybe decreasing fluid intake or decreasing caffeinated beverage intake or whatever it may be. The risk in this situation is a level 2 risk. So this will be a modifier 25 visit with a 99212 overall, plus a 52,000 to indicate CPT for cystoscopy. So I wrote some food for thought for you. So in this situation where the patient came in for a cystoscopy due to BPH, you perform the procedure and then what I typically do is sit the patient down in a separate room, even though you don't need to be in a separate room. You talk to the patient about not just the findings are included in the global for the cystoscopy. So I talk to the patient about the findings, the implications of the findings, and the treatment options, and ultimately the decision to undergo a particular treatment option. So that's a CPT for cystoscopy, and all that stuff that I did is not in the global package of the CPT for cystoscopy. When appropriately documented, that is a modifier 25 event. Okay, hang with me here. So this is a chronic problem, not a treatment goal, or it doesn't matter. It could be an acute uncomplicated, or it could be just a chronic problem at treatment goal or stable. Doesn't matter. It's a level 3 or level 4 problem. However, there's no data when it comes to medical decision making, right? Those of you who are coding geeks, you understand that medical decision making in 2021 and beyond is either based on time E&M visit is either based on time or medical decision making. And within medical decision making, you only need 2 out of the 3 elements. And what are the 3 elements? Problem, data, and risk. And in this situation, the problem could be a level 3 or level 4, it doesn't matter. But the risk when it comes to how you treat this BPH is only a level 2. So you have a 3 and a 2. What is the maximum amount that you can bill? It is a level 2, 99212. And according to this subject matter expert, this will be an insignificant E&M visit, and he feels that you should not bill a 99212 with a modifier 25. I could not disagree more. I have satisfied in this situation all the elements needed for medical decision making, right? Problem and risk, clearly discussed and documented. In addition, the overarching criteria to bill an E&M visit is medical necessity. Was there medical necessity? Absolutely, there's medical necessity because you're dealing with BPH. It is not just some random thing that you thought up. So you have a problem that is a level 3 or level 4, depending on your documentation, depending on a scenario. And then you have a risk that is a level 2. So clearly, this is a 99212 overall evaluation and management. And you're saying that this is not billable it's insignificant, I completely disagree. So anyway, he responded, I think you are misunderstanding me. The medical necessity drives the overall level of service. Clearly, it does. You can have a 3 or 4 and is a significant, separately identifiable service. You can bill a level 2 with a 25. I personally do not consider a level 2 with minimal risk to warrant both unless they're separately identifiable. Most insurance will deny level 2 if not separately identifiable. Just my opinion, and this is a totally subjective matter. I have to disagree. This is not really subjective. This CMS, medical decision making, these rules are most of the time, fairly straightforward. And when it comes to modifier 25, medical decision making, 2021 E&M rules, it is pretty darn straightforward. And in this situation, a level 2, level 3, level 4, 99212, 213, 214 with a modifier 25 can, when appropriately documented, when it's medically necessary, and you have a significant and separately identifiable service, any of these levels can, and when appropriately performed, should be coded with the modifier 25 when you have an appropriate CPT that you perform in conjunction. Okay, so for those of you who may not know what a modifier 25 is, I'm reading from, hang on a second, let me give you the exact citation. I'm reading from chapter 1 of General Correct Coding Policies for National Correct Coding Initiative Policy Manual for Medicare Services. And this was revised January 1st, 2022. There are 8 instances of modifier 25 mentioned in this document. And I will read from number 5. So this is going to be on page 16. Subsection B. The CPT manual defines modifier 25 as a significant, separately identifiable evaluation and management service by the same physician or other qualified health professional on the same day of the procedure or other service. Modifier 25 may be appended to an evaluation and management CPT code to indicate that the E&M service is significant and separately identifiable from other services reported on the same date of service. The evaluation and management service may be related to the same or different diagnosis as the other procedures. There you go, folks. Straight from the horse's mouth. So let's go on here. And my response to his response was that I can tell you that I can have another urology specific subject matter expert back me up on number 1, medical necessity, cystoscopy, and evaluation management for BPH. That is not a treatment goal. Number 2, level 2 through 4 E&M with modifier 24 using the scenario that I described above. I personally typically will bill a 99214 modifier 25 with the above scenario because typically I am recommending some sort of surgery or prescription drug management, prescribing a medication. So there is clear medical necessity for the evaluation and management. It is a chronic problem, not a treatment goal, level 4 problem. I recommend surgery, TURP, or medication, which is a level 4 risk. So a level 4 problem with a level 4 risk is a level 4 evaluation and management visit. So you can have a level 4 visit or you can have a level 2 visit. It doesn't matter. As long as there's medical necessity, as long as there's appropriate documentation for the problem, data, and or risk, you can bill any of the levels when appropriate. Doesn't matter if it's a 2, 3, or 4. Doesn't matter how you feel about it. You can bill either 2, 3, or 4. So we bantered a little bit back and forth about some non-related issues, and I'm just going to go on here. And this is the key. This is the key. His response right here sums up the gist. And I quote, "It is my opinion that a 99212 is not representative of a significant, separately identifiable service above and beyond the pre-service workup. And this is where I completely disagree. I think he is conflating the global package of the CPT with medical decision making. You can have, for instance, the example that I described, a cystoscopy for BPH that the patient was scheduled to undergo. You do the pre-service workup, you do the procedure, you tell the patient the findings, you recover the patient. That is all fine and dandy. That is all included in the global package of 52000, the CPT for cystoscopy. What is not included is the implications, treatment options, and the ultimate decision to go forth with a particular treatment option. That is significant, separately identifiable, and of course, when I document this is clearly documented. My procedure note is separate from the discussion for the evaluation and management. I'm just using myself as an example. You can easily have a significant and separately identifiable service above and beyond the pre-service workup, which could be, as I described above, a 99212, 213, or 214 easily. 215 is going to be pretty tough, but I'm sure there are scenarios. But most commonly, it's going to be 99212, 213, or 214. Just because it's a 212, it doesn't mean that you shouldn't or is not significant, separately identifiable. That is where I completely disagree with this subject matter expert. So we bantered back and forth a little bit more, and I said, I'm definitely going to do a video discussing this issue above, and that's what I'm doing right now. And I'm going to look on here for any comments. All righty, very good. And I'm looking for Facebook. I've got 4 different screens here, so bear with me. All right, so I'm going to monitor the comments there. All right, so let me go on. Banter a little back and forth about what he's working on. And, okay, here we go. I'm going to continue on. This is a long discussion, and I really appreciate this subject matter expert engaging with me in the middle of the day today. So he said, "Hi, Doc. I shared your discussion or your question and concern with a urology subject matter expert of 30 years who's an instructor and a guest lecturer. Here's her response to me. Hope it helps." And I'm just going to read you this. It does not help. It does not do anything. And she quotes, "The NCCI policy manual, which includes the guidance specific to the 25 modifier rules, was updated January 1st, 2022, which I quoted. One of the updates included the elimination of the wording regarding the allowance of the use of a modifier 25 when a more extensive workup is required." This is completely unrelated to what we're talking about. For the decision-making process, previous versions of the NCCI manual even included an example of a patient who has head trauma requiring laceration repair. The nature and location of the injury requires that the patient have a full neurologic evaluation, although standard laceration repair does not include a full neurologic workup, and for this reason, a modifier and evaluation management would be allowed. However, this wording and example have been removed. What remains the directive for minor or major is as follows. This is completely a non sequitur from what we're discussing. But anyway, I read this. What remains the directive for minor or major is as follows. The decision to perform a major surgical procedure is included in the payment for the major or minor surgical procedure and shall not be reported separately as an E&M service. Well, clearly my BPH example is completely irrelevant. But anyway, however, a significant and separately identifiable E&M service unrelated to the decision to perform a minor or major procedure is separately reportable with modifier 25. Doesn't apply in the case above, but in any case, I'll go on. The E&M service and minor major surgical procedure do not require different diagnoses. Well, that's to any coding geek that is, we all know this. If a minor or major surgical procedure is performed on a new patient, the same rules for reporting E&M services apply. Okay? Page 4, paragraph 2. Regardless of the level of service reported, the questions that must be asked, and this is the key right here, was the E&M encounter truly separate from the decision to perform the procedure? Well, doesn't really quite apply in my situation in the scenario that I discussed. Was the E&M medically appropriate and supported by medical necessity as documented? So nothing there refutes what I'm saying, what I outlined above in this scenario. So my response was, thank you for having this person support my position. I appreciate it. And his response was, no, she supported mine. Again, NCCI edits changed the rules to make it more restrictive. These restrictive rules do not apply what we're talking about in this scenario, in this situation. And this is one of the problems when you're talking about coding and billings over messaging. And in this case, this was through LinkedIn, direct messaging. It's hard to have a dialogue just back and forth. Some people will read and interpret things a certain way and kind of ignore, and it's hard to get the context of what someone is trying to say. So my response to his response was, current NCCI edits have not changed the ability to bill my scenario above with the appropriate 99212 through 4 with modifier 25. And I gave a link to the NCCI guideline. And I wrote, I don't think you are understanding what I'm saying. And I present another scenario. And I said, another scenario where your argument fails. Say the patient comes in for a scheduled cystoscopy for hematuria. You find nothing. The pre, intra, and post-service work is clear here. You do the procedure, you tell the patient what you found. Okay, there you go. The patient mentions in passing at the end of the same cystoscopy visit that he has erectile dysfunction. So, cystoscopy's done, everything's done for gross hematuria, so that CPT is done. Now the patient says, hey, I've got ED. Now you sit down with the patient, examine the patient, discuss the implications and treatment options, and guess what? The patient decides to simply observe and maybe try behavioral modification, decreasing alcohol intake, quit watching porn, whatever. So there's clearly medical necessity. It's clear here. The documentation, the physician did document completely. The problem is chronic, not a treatment goal, or it doesn't matter. It could be chronic stable, chronic, not a treatment goal. In this situation, you'll find that it doesn't matter. So the data is a big fat 0 when it comes to medical decision making. The risk, counseling and behavior modification. So what is counseling and behavior modification? A level 2 risk. Once again, level 4 or level 3 problem, level 2 risk. What is this E&M visit that is medically necessary, significant? Clearly, you can identify it, right? Significant and separately identifiable through documentation. So medical necessity, significant, and clearly separately identifiable. You got a level 4 or level 3 problem, and you got a level 2 risk. What is this visit? A 99212. Modifier 25 event, a 99212 visit, clearly billable event. So you should not think that a level 2 or level 3 visit is not a modifier 25 billable event. You have to document it. You have to meet modifier 25 criteria and clearly medical necessity. The reason why you're doing the evaluation management. That's a gimme, in my opinion. And I wrote, again, level of E&M has little bearing on significance. And I hope this makes sense. And I also wrote, yes, I spend too much time perseverating over compliance and being accurate with my documentation and coding. So, and he responded by saying, Doc, my first argument doesn't fail. Your latest example speaks to separately identifiable two separate diagnoses on the same day as a minor procedure, and my guess is the ED will be addressed with RX prescription. 30.6 Medicare Program Integrity Manual, he shortened it as PIM, states, medical necessity is the overarching criteria in addition to the individual elements of a CPT code. So medical necessity, i.e. risk, is the driver. And this is where I completely disagree. Medical necessity may be the driver, and clearly there's medical necessity. But a 212 does not mean that you can't bill a modifier 25. It doesn't matter what your feelings are. It doesn't matter what your opinion is. When you have the elements, you satisfy the elements for medical decision-making, you have medical necessity, you clearly documented, this is a clearly billable 99212, and it is definitely necessary, and it is definitely proper, ethical, legal, and appropriate to bill a 99212 with a modifier 25, and it is not this. Just because you bill a 99212 doesn't mean that it is insignificant. So my response was, I'm hearing you think that medical necessity equals risk. Medical necessity is not the same as risk, and that is the bottom line. You can have a medically necessary E&M visit while having a low risk outcome or plan. I just gave two examples. Medical decision-making does not care about feelings. It cares about problem, data, risk, and medical necessity. And I think I hear where you're coming from now, and I completely disagree with his stance that 99212 should not be appropriate to bill with a modifier 25. And I went on to say that in the second scenario, the ED was addressed with behavioral modification, not prescription drug management, as he had assumed. Again, a level 2 risk, a 99212 visit that is medically necessary, significant, separately identifiable, and a clearly modifier 25 appropriate event, despite the fact that this is a 99212 low risk visit. So great discussion with him. Let me know what you think. And I want you to fact check me, dispute me. Tell me where I'm wrong. Tell me where I'm wrong. So just because somebody's a subject matter expert, whether that is him or somebody else or myself, it doesn't mean that they're correct. You have to go back to NCCI, you have to go to CPT, you have to go to evaluation and management, the AMA CPT guidance, go to the root and apply logic, apply reasoning, and come up with your own decision and your own conclusions, and never take what someone says as gospel unless you can back that up with documentation, reason, and logic. And I see no comments here. I guess I scared people away. As usual, thank you for the privilege of your time. Please take care of yourself and take care of each other. I look forward to interacting with everyone here. And if you're going to be at the Urologist Coding Workshop on Saturday, I will see you bright and early Saturday morning. Bye-bye.